Well, hello, and it's good to be with you. My name is Professor Robert Booy, and I'm pleased to be Chair of the Scientific Committee of the Immunisation Coalition and to be presenting this short talk on the changing epidemiology and prevention of meningococcal disease, especially as it applies to Australia. Now, meningococcal disease is always in the media, and especially in winter and early spring when case numbers increase. And we've seen multiple examples of this just in the last couple of weeks in different parts of Australia: Victoria, New South Wales, Western Australia, Queensland. And getting the most recent data that goes up until June the 9th, which was last week for me, shows us that in Australia so far, we've got many more cases this year than we had last year, and we had more cases last year than the year before. If in the bottom right hand, you can see we've got 58 cases, and the great majority of them are due to meningococcal B. On the bottom left, you see 44 cases. Given that the not groupable, which makes up 8, could actually be as well significantly dominated by B, we can see the problem that in Australia at the moment is that serogroup B is by far the most common. Of those that can be serogrouped, it's 44 or 50, which is 88%. The world has changed and it just keeps changing. Australia has had routine use of a meningococcal B vaccine for infants and teenagers in South Australia now for over 4 years. And for the last year, we've had it routine for Indigenous children who are in their infancy. And as I say on this slide, the more things change, the more they stay the same. The epidemiology of meningococcal disease is fascinating, having 2 peaks, one in early infancy and another one in late teenage years. And we did a study in the UK which showed important risk factors included being a school student with the mixing involved, multiple intimate kissing contacts, not one but multiple ones, and exposure to smokers who smoke. But the key point is that they cough. They're more likely to be a carrier and more likely to cough. And these risk factors were actually shown way back in 1918 in a British Medical Journal article, and we followed up nearly 300 survivors and controls in the early 2000s and showed similar risk factors. Paper just published, or in fact it's only in press from South Australia, shows that the vaccine effectiveness of B vaccine in South Australia has been largely maintained. But what was really interesting and an additional finding was that in South Australia, the teenagers who were vaccinated against meningococcal B got in the order of 33% vaccine effectiveness for the prevention of gonorrhea in adolescents. That's in the second to last line. And the argument now becomes that if the Men-B vaccine actually protects against more than Men-B, other meningococcal serogroups, and also Neisseria gonorrhoeae, that needs to be factored in to any cost-effectiveness analysis. So a paper, again, just published from Spain, a case control analysis of use of vaccine in Spanish children, looked over the course of several years and found 300 or so patients and 1,200 controls, and the effectiveness of complete vaccination with at least 2 doses was 76% against invasive meningococcal disease by any serogroup, so not just B, but other serogroups as well. And in the last line, vaccine effectiveness in Spain, in this case control study just published in the New England Journal, showed 82% protection against non-serogroup B disease. So we're seeing a vaccine with wider implications, licensed for B, but seemingly preventing Neisseria gonorrhoeae and Neisseria group B and non-group B as well, meningococcal disease. The Oxford Vaccine Group published only last year an 11-year follow-up of children, and essentially they showed that antibody levels were maintained best if your last dose of meningococcal B was at 12 months of age or older. if you had your vaccines in infancy, the memory was not as good. So looking at the last paragraph, the highest serum bactericidal activity responses were observed in patients who had received a preschool dose of vaccine, and B cell memory was not sufficiently good to prime in kids under 1 year of age. So we've just gone through a pandemic in the last 3 years, and it had major impacts on health, the social distancing, mask wearing, hand washing, etc., led to a reduction in viral infections, firstly COVID, but also flu. But we also saw secondary reductions in bacterial infections like meninge, strep, and pneumococcal disease. The UK started lifting its restrictions early towards the end of 2021, and they very quickly got a surge in university-based teenagers of meningococcal B disease. The surge occurred from September when they went back to university. They run on a different year to us. We're January, December, but they go back to uni at the beginning of September. Looking at 15 to 19-year-olds and 20 to 24-year-olds, there were increased numbers, and most of them were in students in an educational institution. Going back now in history for more than a century, Group A meningococcal has traditionally been the main cause of disease, especially during both the First and the Second World War, but also a surge in the 1950s. And then curiously, meningococcal A without vaccination went away, and it's argued that because of socioeconomic improvements, meningococcal A did not spread as easily, and so it went away not because of vaccination, but because of improved socioeconomic status, less crowding, less transmission. Looking now to the data in Australia for the last 30 years, we can see that back in the early 2000s, we had a surge of meningococcal disease, not A, because it was gone by then, but B and C. And you can see that during the 2000s, that there was a dramatic decrease again of disease, mostly of C, because we introduced a vaccine in 2003 in Australia for routine vaccination of both babies and teenagers. But curiously, B disease also dropped by more than a half without an intervention. So once again, we see meningococcal disease numbers falling, sometimes in response to vaccination, but sometimes in response to other factors. So both meningococcal A and meningococcal B have fallen in Australia and many other countries as a consequence of other changes in the epidemiology, not just vaccination. So here we see a breakdown by meningococcal group. C was the one with the biggest decline in the early 2000s, but B declined as well without a vaccine being available in Australia. There was one in New Zealand. And then in the late 2000s, the teenies, 2017, we saw a surge of all meningococcal serogroups, and the simple explanation for why suddenly all four surged was that we had a major influenza outbreak, which predisposed to secondary meningococcal disease, whether it was C, Y, W, or B. All of them increased in 2017 with the surge of flu. We published last year in the Medical Journal of Australia on the impact of social distancing and other factors which reduced influenza and also then reduced meningococcal B disease. And here you can see some more of the data from Australia from the last few years. And suddenly, during the pandemic, by 2001, we had historically lowest levels of disease ever. And so social distancing, hand washing, mask wearing contributed to that. But what goes around comes around again. And now in 2022, we had more disease and even more this year in 2023. This slide is from our paper in the Medical Journal of Australia last year, showing the impact of influenza outbreaks causing small outbreaks of meningococcal disease. It's thought that the lining of the throat is damaged, allowing a colonizing meninge B to invade after influenza has first done damage to the mucosa. So both flu and meningococcal disease are diseases of crowding. There isn't time to go into more, but here we reference the landmark 1918 paper and the risk factors observed even then of prior influenza, overcrowding, high carriage, and so on. This slide reminds us that meningococcal C was well controlled by vaccination beginning 20 years ago. And now for the last 2 years or so in Australia, we've had routine vaccination of infants of Indigenous background. Aboriginal and Torres Strait Island children are routinely offered free vaccination on the NAP, and that's a major advance. So I'll let you read that. Time is getting short. Looking now to the meningococcal C story from 20 years ago, we noticed that risk groups included infants between 1 and 5, but also teenagers and even adults in their early 20s. So vaccination was introduced widely in 2003, and by 2016, there'd been a 99% reduction in meningococcal C disease, but there was more than 50% concurrent reduction in meningococcal B disease, even though we didn't have a vaccine. The C surge in 2017 was especially in men who have sex with men, but it was especially also as a result of prior flu virus infection. We saw the same with men B. And by 2020, we had historically low levels, I've pointed out already, but the last 2 years we've seen surging disease again. And I showed you that in 2023, by June this year, 88% of serogroup cases were meningococcal B in Australia. There's a vaccine that's been recommended and introduced for Indigenous children. It was also introduced 3 months ago for all infants in New Zealand, and it's available and supplied routinely and free of charge on national immunisation programs in half a dozen European countries, including Portugal, Spain, France, England, and Ireland. The South Australian study is worth commenting on for a couple of minutes. It was a great piece of work. The local public health got together with the academics and the routine system, and they introduced vaccination first as a trial in teenagers and as a cluster randomised. So some schools got vaccination in 1 year, and then the other schools got vaccination for all teenagers in the second year. And they looked at the impact on carriage of men B and also the impact on disease. The key point was to see if carriage could be impaired, and the study gave a negative result in that regard. It was not able to prevent carriage, but it did importantly prevent disease, so that meningococcal B disease in teenagers in South Australia went away to very low levels in 2 to 3 years. No time to talk about meningococcal W, other than to say that the surge in 2017 occurred across many age groups, as you can see here. But the first group to show a reduction in 2017 was the group who was vaccinated. And you can see that reduction in 15 to 19-year-olds. They were being offered vaccine at a state level in many states beginning in 2017. And already you can see the impact. Nationally, it was introduced in 2018, and within a couple of years, by 2018, the combination of vaccination routinely given to both babies and to teenagers, but also the epidemiology changing because there was less influenza driving disease. So those two things led to a decline across virtually every age group, which was very impressive in 2018. And why I'll leave suffice to say that the silver linings of having no very limited contact between people in 2020 and 21 led to reductions in many viral and bacterial diseases, as I've already alluded to. So if you look at the red writing in 2020, for the first time ever in Australia, we had fewer than 100 notifications of meningococcal disease. And in 2022, the numbers were back up to around 150, and this year may well be even higher because the numbers are rising rapidly. So as reported, the sudden decline of so many infections hadn't been seen before, and many illnesses, viral and bacterial, were wiped out. And however, we've now got an immune debt whereby people who haven't had exposure to colonisation or infection have reduced immunity and potentially increased susceptibility, especially young children and primary school age children, such that we may well get surges, and we are seeing surges not only in respiratory viral infection, but in secondary bacterial infections like group A strep, pneumococcus, and the meningococcus. So I'd like to leave it there in order to allow time for some discussion and questions. Thanks very, very much for your attention.